Hello, I'm Dr. Iftikhar Kalu. I'm a consultant in the Division of Cardiovascular Diseases at Mayo Clinic and the Cardiovascular Center, and I'm also a professor of medicine at the Mayo Clinic College of Medicine. I'm pleased to have this opportunity to summarize for you our upcoming article in the Mayo Clinic Proceedings, which is titled A Perspective on the New American College of Cardiology and American Heart Association Guidelines for Cardiovascular Risk Assessment. We developed this article after collecting feedback from preventive cardiologists across the Mayo Foundation, including campuses in Rochester, Arizona, and Florida. Our article goes over what's new in the guidelines, what are some of the limitations of the guidelines, and how we might modify these at an individual or institutional level. So the new elements in these guidelines include that the risk estimators are derived from relatively contemporary cohorts that were established by the National Heart, Lung, and Blood Institute. There are nearly 25,000 individuals from whom data were used to develop these risk prediction equations, including African Americans. So for the first time, we do have available risk equations that permit us to calculate or estimate risk in this cohort or this ethnic group. So this is clearly an advance. Secondly, the guidelines include stroke as a cardiovascular endpoint, and they focus on what are called hard endpoints such as heart attack, stroke, or death from heart attack and stroke. Thirdly, there is ability to estimate risk not only for the 10-year time frame but also lifetime risk. And lastly, these guidelines emphasize the need for shared decision making when estimating risk and then acting on that risk in terms of medication. The guidelines recommend 4 adjuncts to be used when a person is at intermediate risk or the risk is indeterminate, and these include family history of cardiovascular disease, coronary artery calcification, ankle brachial index, and C-reactive protein. One of the main limitations we feel is that family history has been relegated as an adjunct rather than something that's done part of the cardiovascular risk assessment. Another limitation is that the number of African Americans that are included in the cohort is somewhat limited, and therefore the risk estimates or the equations may not be very accurate. There is no guidance on how we might use information from adjunct measures for risk assessment such as coronary artery calcification in modifying the estimates of 10-year risk. Another limitation is that there are no equations available for ethnic groups such as Hispanic Americans or Asian Americans. For now, the guidelines recommend using the equations that are available for non-Hispanic whites, but that's certainly going to lead to some inaccuracy when applied to these ethnic groups. Another limitation of these equations is that their performance in other cohorts has varied quite significantly. So we will probably need additional validation studies for these equations. Now, what are some of the adaptations or modifications that we are recommending? Our first recommendation is that family history should be part of every cardiovascular risk assessment. It should not be relegated to being an adjunct. Now, how one might modify the risk estimates based on the presence or absence of family history is not yet clear, and that will depend on the clinical judgment and how strong the family history is. The Canadian Cardiovascular Society, for example, recommends doubling the estimated risk if there is presence of family history. Secondly, we point out some of the caveats related to interpreting or using adjuncts such as ankle brachial index or C-reactive protein. For example, C-reactive protein can be influenced by many factors, including infection, injury, metabolic syndrome, use of oral contraceptives. So when CRP is elevated, one needs to keep that in mind. We feel that three modalities that may be useful should be considered when the risk estimate is indeterminate or the patient has an intermediate risk profile. The first of these is carotid ultrasound, which was not recommended for use in the guidelines. This test is non-invasive, doesn't involve any radiation. It provides a direct visualization of the intima media thickness as well as presence or absence of plaque. There's more than 30 years of experience using this test both in the clinical and research realms. The second modality we recommend for use is aortic pulse wave velocity. This is a measure of arterial stiffness. It can be obtained non-invasively. It's relatively inexpensive. And there really is a lot of data out there showing that this measure is an incremental predictor of cardiovascular outcomes. Lastly, we would recommend selective use of lipoprotein A, a circulating LDL-like particle that is clearly associated with cardiovascular risk and is a causal factor rather than a marker. Finally, we make the point that current risk estimators have significant limitations because these are derived from populations, and when one attempts to use them in individuals, there is clearly going to be inaccuracy. So we highlight the need for additional research in this area, in particular how we might use periodic assessments either by imaging or non-invasive testing of arterial function to assess for plaque vulnerability or the risk of cardiovascular events. Thirdly, we highlight the use of new genetic markers. The value of these markers is that although they are somewhat modest in their effect size, they are most of the time not related to known risk factors. So they can be compiled into genetic risk scores which may provide additive risk prediction information. Lastly, we also need newer statistical methodologies to improve risk prediction equations. Overall, we agree with the guidelines that represents a commendable effort by the writers to sift through a lot of literature and come up with evidence-based recommendations. However, we also point out some of the limitations of these guidelines and provide potential adaptations that might be useful in our practice from day to day. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.